so that we can have best evidence-informed care based on robust educational programs. So welcome. So it's my pleasure to introduce Dr. Elena-Bianca Babir, who has completed her internal medicine and nephrology training at UBC and is currently pursuing additional training in kidney transplant and onconephrology at the Mayo Clinic in Rochester. Her interests are include improving access to immunotherapy in the kidney transplant population. And to this end, she's been following a cohort of kidney transplant patients on immune checkpoint inhibitors over the last year. And I believe that's the basis of this conversation. So welcome, Elena, and thank you very much for doing this for us. Over to you.
Thank you, Dr. Levin, for the introduction. I'll start sharing my slides here. All right, is that
perfect?
Is that okay? Okay, excellent. So as Dr. Levin mentioned, the talk or the presentation was motivated by my experience looking after a cohort of these patients over the last year while I was a kidney transplant fellow. And this year I'm an onconephrology fellow and have the opportunity to continue to follow these patients. And I think we'll see an increased frequency of immunotherapy use in kidney transplant recipients as we start to see more and more encouraging data come up. Now, full disclosure, I'm not sure what the practice is locally, but I'm hoping that we can have a conversation about that at the end. But I'll be sharing the Mayo experience that I've had with you, as well as a review of the literature to date. These are my learning objectives, which were shared ahead of time. I have no disclosures. And so I'll start by making the case why access to immune checkpoint inhibitors in solid organ transplant recipients is vital, but specifically I'll be talking about kidney transplant recipients. We'll review the risks associated with immune checkpoint inhibitor use in transplant patients, risk mitigation strategies, and then I'll talk a little bit about our local protocol at Mayo and our experience to date, and then just briefly summarizing with an approach to patient-centered decision-making when we have these difficult conversations. So while I'm not an oncologist, I know enough to recognize that immune checkpoint inhibitors have revolutionized the field of oncology, and there was a Nobel Prize in Medicine given to Drs. Allison and Honjo in 2018 in acknowledgement of this. Immune checkpoint inhibitor therapy as single agents or in combination with chemotherapies are used as first or second line treatment for about 50 cancer types, and currently clinical trials evaluating T-cell modulators make up the majority of all oncology trials. 2/3. They are not new therapies. They've been around since 2011 with cytotoxic T lymphocyte antigen 4, ipilimumab, being approved in 2011 for the treatment of melanoma. And since that time, additional agents have been approved with program cell death 1 protein and its ligand following, and most recently in 2022, lymphocyte activating gene 3 monoclonal antibody directed was approved as well, but we don't see its clinical use as often, and so I won't be talking about any LAG3 agents today, just focusing on CTLA4, PD-1, and PD-L1 inhibitors. Why does it matter within kidney transplant recipients specifically, or why is the treatment of oncologic complications very important in the treatment of kidney transplant recipients? It's because over the last 5 to 10 years, we've seen that cancer-related deaths have caught up with cardiovascular-related deaths post-kidney transplant. This figure that I have here is from Dr. Chadban's group in Australia using the Australia and New Zealand database, and this includes data from 1980 all the way to 2018, and at that time, in the first year post-transplant, cardiovascular deaths still exceeded cancer-related deaths, although more recent data shows that cancer-related deaths are starting to exceed cardiovascular death after 1 year post-transplant. We know that in the kidney transplant recipient population, the most frequent cancers are skin cancers, with cutaneous squamous cell carcinoma occurring most frequently, followed by melanoma. And we also know that immunotherapy is particularly effective in the general population for these types of cancers. Specifically for cutaneous squamous cell carcinoma, there are objective response rates reported in the literature of 34 to 50%, with durable responses associated. And then we look at cancer-related outcomes in the kidney transplant recipient population, and despite novel therapies, we see that there have been no improvements in the last 3 decades. So in 1987 to 2016, doctors Blosser, Haber, and Engels linked US transplant and cancer registry data looking at 101,000 recipients of kidney transplants. And they broke up the data over 3 decades, 1987 to 1996, 1997 to 2006, and 2007 to 2016. And they found that there was no significant change in the incidence of cancer overall, except, interestingly, there were fewer incidences of prostate cancer. And more importantly, they found no significant change in mortality post-cancer diagnosis, with the exception of non-Hodgkin lymphoma. So there is room for progress. Why are solid organ transplant recipients at increased cancer risk? There are a few different theories. The first is that with decreased immune surveillance as a result of cumulative immunosuppression, you have tumor immune escape. There was a case series from Tel Aviv's Rasky Medical Center where they used flow cytometry-based T-cell immunophenotyping on 3 solid organ transplant recipients who had been on tacrolimus monotherapy as maintenance immunosuppression, and they were 5 to 25 years out from transplant. They included 2 deceased donor kidney transplant recipients and 1 orthotopic liver transplant recipient. And what they found was that these patients had a low percentage of naive CD4 and CD8 T cells and an increased percentage of terminally differentiated effector memory T cells. And so you can see how if you have fewer naive T cells around, it's easier for neoantigens to escape immune surveillance. And we also know that malignancies are primarily controlled by T cell responses. There's also an increased risk of oncogenic viruses in the kidney transplant population or the solid organ transplant population in general, specifically EBV and Merkel cell polyomavirus. There's also a potentially higher baseline risk in patients with end organ disease, and thinking about our population in particular, the increased risk of renal cell carcinoma for patients with acquired cystic disease. And lastly, we are probably seeing worse outcomes in the kidney transplant recipient population, and again, solid organ transplant population more broadly, due to less aggressive cancer care, for concern related to comorbidities, but also for concern related to the possibility of organ rejection, specifically with regards to immune checkpoint inhibitor therapy. So how do immune checkpoint inhibitors work? They're monoclonal antibodies that are T-cell targeted immunomodulators. Their purpose is to interfere with tumor immune escape by inhibiting naturally occurring T-cell checkpoints. So often when I explain the mechanism to patients, I describe them as unleashing the immune system. Transplant immunosuppression, unfortunately, is geared towards inhibiting the alloimmune T-cell response by targeting signal 1, 2, and 3. So we can see how these 2 agents may not work synergistically. So just as a brief review of transplant immunosuppression, we have T-cell activation mediated by 3 signals. So signal 1 is the original recognition of a naive T-cell of a foreign antigen. The antigen is loaded onto an MHC molecule on an antigen-presenting cell, and the naive T-cell's T-cell receptor binds to this and activates signal 1. Signal 2 is co-stimulation, where CD28 on the naive T cell binds to CD80 or 86 on the antigen-presenting cell. And signal 3 is the release of cytokines such as IL-2, which allow T cell proliferation and differentiation. And you can see here we have our calcineurin inhibitors that inhibit signal 1 downstream. Signal 2 is inhibited by belatacept. Signal 3 is inhibited by basiliximab or mTOR inhibitors. And the way that immune checkpoint inhibitors work, and we'll talk specifically about anti-CTLA4, anti-PD-1, and anti-PD-L1 agents, is they're monoclonal antibodies that are directed against these targets. So CTLA4 is expressed by naive T cells that are residing in lymphoid organs. And after signal 1 and signal 2 have been activated, intracellular vesicles containing CTLA4 are translocated to the surface of the T cell, where it is expressed and binds with a higher affinity than CD28 has to CD80 and 86. And by doing that, it prevents signal 2. And the motivation for this signal, this checkpoint inhibitor, or this immune checkpoint, I should say, is to prevent over-aggressive responses in the setting of normal immune activation. Peripherally, T cells will express PD-1, and they will bind, PD-1 will bind to PD-L1 either on tumor cells or on tubular epithelial cells in the kidney. And this is a way for the body to recognize self and to ensure that T cells that otherwise have gotten through the negative thymic regulation and may be reactive to self do not go after self antigens. Immune checkpoint inhibitors stop this process from occurring by blocking binding of CTLA-4 or PD-1 and PD-L1. And these antibodies are directed to these proteins. And so here we have a schematic depicting the function of a CTLA-4 immune checkpoint inhibitor. So you have antigen-presenting cells within tumor tissues that pick up tumor-associated antigens, migrate to lymph nodes where they encounter naive T cells. These are activated, and you see here CTLA-4 within an intracellular vesicle, which then is expressed on the surface and acts as an immune checkpoint, and then an immune checkpoint inhibitor would block that from happening. And similarly, in the periphery, we see a naive T cell with PD-1 like PD-1 here, as well as PD-L1 expressed on the cancer cell and a tubular epithelial cell. And this is how the immune checkpoint works here. And then blocking these two signals would be how the immune checkpoint inhibitors work. So based on their mechanism of action, you can understand that two concerns with regards to ICI use in the kidney transplant recipient population would be, number one, the risk of allograft rejection, as we're inhibiting mechanisms that may potentially have led to allograft tolerance, and we're also amplifying T cell responses, which increase the risk of rejection. And the other concern is that potentially by continuing maintenance immunosuppression in these patients, we're blunting the anti-tumor efficacy of immune checkpoint inhibitors. But I will get straight to the punchline before reviewing the recent data. Looking at all of the case reports and case series that were included in a recent meta-analysis by Portuguese et al., which I'll talk about in a moment, I plotted out the rejection rate over the years, and I found that from 2014 to 2017, the observed rejection rate was 40%. From 2018 to 2020, 60%. And from 2021 onwards, it was down to about 20%. And the reason for that, I think, is we become more accustomed or more comfortable modulating immunosuppression and knowing that by maintaining higher levels of immunosuppression, we are not significantly decreasing objective response rates. And we are seeing less rejection with this, which makes sense. And then in terms of the type of rejection that we've seen previously, when we look at these reported percentages, it's typically been acute cellular rejection or mixed rejection. And prior data has identified that rejection risk is influenced by the type of immune checkpoint inhibitor therapy, the number and type of immunosuppressive agents the patient discontinued on at the time of initiation of immune checkpoint inhibitor therapy, and whether the patient has a prior history of rejection or not. But I think before moving forward and looking at the data, that the one theme you're going to see is that cancer progression remains the most frequent cause of premature death rather than allograft failure post-rejection. And this may be a feature that's more unique to kidney transplant recipients due to the availability of organ replacement therapy with dialysis. And so we're lucky in that respect, as we can offer that to patients, especially since not all patients who develop allograft rejection progress to allograft failure. Previous reported rates have been about 50%, and that hasn't changed. But if the rejection rate is 20%, then the allograft failure rate is 10%. So the overall prognoses from an allograft standpoint are improving. All right, so the first manuscript I want to review is the meta-analysis by Portuguese et al. This was a systematic review of case reports and case series from January 1st, 2010 to November 1st, 2021. It was published April 2022. It included 119 patients with 64 kidney transplants. So it wasn't just looking at kidney transplants, but kidney transplant recipients did make the bulk of the patients. The median time from transplant to the start of immune checkpoint inhibitor therapy was 6.6 years. 75% of the patients received PD-1 inhibitors, 12.6% received CTLA-4 inhibitors, and 1.7% received PD-L1 inhibitors. So what they noted was that allograft rejection occurred in 48.4% of kidney transplant recipients, with allograft failure occurring in 25% of kidney transplant recipients. So again, 50% rejection rate, with about 50% of those patients progressing to allograft failure. The median time to rejection was 3 weeks, with an interquartile range of 1.7 to 5 weeks. And this has remained consistent across more recent data as well. And most cases occurred within the first month, with 81% occurring within the first 7 weeks. There was a numerically higher rate of rejection in patients with a prior history of rejection, 6 out of 12, but that was not statistically significant. Allograft PD-L1 lymphocyte positivity was associated with increased rejection risk, but only one of these patients was a kidney transplant recipient. The remainder were liver transplant recipients. And in kidney transplant pathology, PD-L1 staining has not been clinically validated, so we need to take this with a grain of salt. In kidney transplant recipients, everolimus, not sirolimus, demonstrated a protective effect, but only 16 patients were on everolimus and 24 were on sirolimus. And the reason they looked at this was because one of the largest cohort studies to date, retrospective cohort studies to date, had identified a signal that patients who were on sirolimus had a lower association with rejection, but they did not see this. They did see an overall trend of decreased rejection risk with increased number of immunosuppressive agents, although there were not that many patients that were on triple immunosuppression, but the rejection rate was lowest on triple immunosuppression. It was similar on monotherapy or dual therapy, and then of course patients who were on no maintenance immunosuppression had an 85% rejection rate, and then 40% about for monotherapy or dual therapy. This was almost statistically significant. They looked at immune-related adverse events, as this is common in the non-transplant population, and they still found 13.4% of the cohort had immune-related adverse events, including pneumonitis, dermatitis, colitis, and hepatitis, and this was a treatment or dose-limiting toxicity in some of these patients. Interestingly, there had been prior signals that suggested that the further out a patient is from transplant, the lower their risk of rejection, but they did not see this, although their finding was not statistically significant. To compare a more recent study, and this is the only prospective trial that has been published to date, Carroll et al., and Dr. Carroll is a nephrologist in Australia, it was a multi-center phase 1 study, and it was designed to assess the safety of a standard dose of nivolumab in kidney transplant recipients who either had incurable cancer or metastatic solid tumors, who were otherwise eligible for treatment with immune checkpoint inhibitor. They had 17 kidney transplant recipients who received a PD-1 inhibitor and 1 kidney transplant recipient that received a PD-L1 inhibitor, although only 16 of those 17 received nivolumab. 1 patient received cemiplimab, and the PD-L1 was atezolizumab. Their inclusion criteria was stable allograft function over the prior 3 months with a creatinine less than 180, low or intermediate immunologic risk based on either no preformed DSA at the time of ICI initiation or a DSA of 600 to 4,000 at the time of therapy initiation. That was the intermediate risk category. None of these patients underwent preemptive reduction in their maintenance immunosuppression prior to the initiation of ICI therapy. And so this was what they brought to the table because they acknowledged that in all prior retrospective studies, most of the patients had undergone immunosuppression, maintenance immunosuppression reduction prior to starting immune checkpoint inhibitor therapy. So their question was, is the high rejection risk associated with these changes to maintenance immunosuppression, or is it all related to immune checkpoint inhibitor therapy, or a combination of the two? So to look at the baseline characteristics, specifically their rejection risk factors, in terms of DSA, 4 patients had detectable DSA prior to initiation of ICI with mean MFI of 2,500. And the duration of immunosuppression prior to requiring ICI initiation was 15.6 years. So most of these patients were quite far out from transplant. Number of HLA mismatches you can see here. So 0 to 1, 5 patients, 2 to 3, 3 patients, and 4 to 6, 7 patients. 2 patients, the HLA mismatches were not known. With regard to the maintenance immunotherapy, again, this was not changed prior to the initiation of ICI. There was 9 patients total on dual immunosuppression. And looking at the breakdown, 4 patients were on CNI and prednisone, 2 patients on everolimus and prednisone, or everolimus and azathioprine, 2 patients were on CNI and mycophenolate, and 1 patient on azathioprine and prednisone. 7 patients on triple immunosuppression with CNI, mycophenolate, prednisolone, or everolimus, azathioprine, and prednisolone, and 1 patient on monotherapy with mycophenolate, but this was an HLA identical renal transplant. None of these patients received ICI as first-line therapy. They received a median of 3 pembrolizumab infusions. The median follow-up time was 28 months, and they noted a kidney allograft rejection rate of 12%, which is significantly lower than what had previously been reported, 1 of whom progressed to allograft failure. So again, 50% of those who developed rejection progressed to allograft failure, but the rejection rate was much lower. Death-centered kidney allograft survival at 2 years was 89%. And all deaths were from progressive cancer, in keeping with prior themes that progressive cancer is still the main cause of premature death in these patients. So looking at the details of these rejection episodes, the first patient received a living donor kidney transplant at a 1 out of 6 HLA mismatch. Unfortunately, their DSA status was not explicitly stated in the manuscript. However, Dr. Carroll does mention that neither of these patients developed de novo DSA post-rejection episodes. So I'm interpreting that as these were not the patients with pre-existing DSA, but that was not explicitly stated. Patient 1 was on azathioprine and prednisolone, and the treatment they received for their rejection was ATG 5 milligrams per kilogram and Plex for 13 cycles. And they had an ACR BANF1B rejection. And the reason they used Plex was not to treat the rejection, but it was to remove nivolumab to decrease the risk of ongoing rejection. So you can see that patient 1 received 2 doses of nivolumab, was admitted to hospital, biopsied, treated, and then second biopsy did not show any response to therapy, and this patient progressed to allograft failure. Patient 2 was also a living donor kidney transplant recipient with 1 out of 6 HLA mismatch with prednisolone, azathioprine, and everolimus as maintenance immunosuppression. They had an ACR BANF2A rejection, and they responded to therapy with ATG 3 milligrams per kilogram and received only 3 cycles of Plex. Interestingly, that the one difference between patient 1 and patient 2 is that as they were doing this study, they were monitoring urine cytokines, specifically CXCL10, which is a cytokine associated with rejection. And they found that patient 1 had elevated levels of this urinary cytokine even before starting the immune checkpoint inhibitor. So their suspicion was that potentially they may have had subclinical rejection, which was amplified with the initiation of nivolumab. The second patient received 3 cycles of nivolumab prior to experiencing their rejection as compared to the 2 cycles. These were administered every 2 weeks, and so you can see that at about 5 weeks, and here at about 8 weeks, you had the rejection episodes, which is in keeping with what the previous data had shown in terms of timeline of rejection. They tried to see whether or not there were factors affecting progression-free survival with regards to choice of immunosuppressive agents, specifically does prednisolone use decrease progression-free survival, as well as the number of immunosuppressive agents, and there was not really any significant differences. They also looked at progression-free survival by cancer stage, but this is tricky because they were treating a variety of cancers, and so it's really difficult to compare the effectiveness when you don't have one type of malignancy that you're treating. And again, no significant difference here looking at metastatic disease versus advanced local regional disease. So what tumor types were they looking at? The majority was still cutaneous squamous cell carcinoma of the head and neck with 6 patients presenting with this. Then they had squamous cell carcinoma of the head and neck involving the oropharynx. 1 patient had this. Renal tract carcinoma, 2 patients. Hepatocellular carcinoma, 1 patient. Non-small cell lung cancer, 1 patient. Melanoma, 1 patient. Merkel cell carcinoma, 2 patients. And colorectal cancer, 1 patient. Overall, they found a 53% objective response rate, and that's made up of complete response as well as partial response and a duration of response of 27.7 months. And this is comparable to the general population, so it's encouraging knowing that a lot of these patients had continued their maintenance immunosuppression. So we're seeing decreased rejection rates as well as comparable efficacy. Of that 53% objective response rate, 3 had complete response with head and neck squamous cell carcinoma, and 1 had complete response with colorectal cancer, and then 3 of the head and neck squamous cell carcinomas had partial response. 1 patient with bladder cancer had partial response, as well as 1 patient with hepatocellular carcinoma. So how does this compare to the objective response rate that Portuguese et al. Noted? They reported an objective response rate of 35.7% in the cutaneous melanoma group, with a duration of response of 8 months, 18.5% in the hepatocellular carcinoma group, with a duration of response of 6 months, and then 68.2% in the cutaneous squamous cell carcinoma group, with a 9-month duration of response. And they did not note a clear inverse relationship with a number of immunosuppressive agents. So the numbers are comparable. But the difference was that they had noted a higher frequency of rejection because overall, the patients that they had looked at were on lower doses of immunosuppression. And it's encouraging to see that the objective response rate is comparable with higher doses of maintenance immunosuppression in Carroll's prospective study. There's also a case series published by Haag et al. In which they looked at 7 deceased donor kidney transplant recipients with advanced cutaneous squamous cell carcinoma. In Belgium from 2018 to 2022, they all received cemiplimab, which is a PD-1 inhibitor. No patients had pre-existing donor-specific antibodies, and none had a history of rejection. 3 were maintained on low-dose methylprednisolone alone. 1 patient was on tacrolimus monotherapy, and 3 patients received 2 or more immunosuppressive agents. They saw 1 episode, so 14% of rejection, band grade 2A ACR, and unfortunately this patient progressed to failure with nephrectomy for allograft rupture. This was the patient who was maintained on prednisone monotherapy, and their objective response rate was 42.8%. The largest retrospective cohort study to date was done by Dr. Murakami et al., and they looked at ICI use in kidney transplant recipients from January 2010 to May 2020, so older data. They had 69 patients, 66 kidney transplant recipients with advanced squamous cell carcinoma were included in that group, and cutaneous melanoma. They did have a comparator group, 23 stage-matched kidney transplant recipients with squamous cell carcinoma and 14 with melanoma not receiving immune checkpoint inhibitors. They saw a 42% rejection risk, and this is where that frequently quoted number came from for a study, with only about 50% of those patients being biopsy-proven rejection, and they saw 19 of 29 patients progressing to allograft failure, so 65%. The comparator group had a lower rejection risk of 4.3%, so this is with decreased immunosuppression alone. Of the 14 rejection episodes they saw that were biopsy proven, 50% had acute cellular rejection and 50% had mixed ACR and EBMR, with 9 of those patients having V lesions. The median time to rejection was 24 days, again in keeping with the trend, with 80% of rejection episodes occurring within the first 60 days. And their objective response rate was 36% in cutaneous squamous cell carcinoma and 40% in melanoma subgroups. So interestingly, this was lower than what we saw with Portuguese's analysis. overall survival did not differ between those who experienced rejection and those who did not. And in the cutaneous squamous cell carcinoma subgroup, the immune checkpoint inhibitor group experienced an increase in median overall survival. So 19.8 months versus 10.6 months, and this was statistically significant. The median overall survival did not differ in the melanoma subgroup, but this was not statistically significant. When they looked at potential rejection risk modifiers, they noted a signal that potentially mTOR inhibitor use was associated with fewer rejection episodes. But this was statistically significant. They also noted that dynamic steroid use, which I'll explain in a moment, and mTOR inhibitor as maintenance immunosuppression was associated with a decreased rejection risk. So 7 patients did not experience rejection and 1 did, but this was not statistically significant. Another thing they looked at was whether or not the use of AIN-associated drugs increased the risk of rejection. And they did not find that. So for patients without kidney transplants, we often worry about ICI-associated AIN, and our recommendation is to stop AIN-associated medications like PPIs, NSAIDs, or antibiotics like Bactrim due to the increased risk that we know exists. But this was not a trend that was noted in kidney transplant recipients based on her retrospective analysis. So dynamic steroids and mTOR inhibitors is something that Dana-Farber is currently using. And the dynamic steroid regimen they use is prednisone 40 milligrams daily for 3 days, starting from day 1 of ICI initiation, 20 milligrams for 3 days, and then 10 milligrams for the rest of the cycle. And they also convert patients to mTOR inhibitors if possible with a target trough level of 4 to 6. And the reason I highlight that is because there is a recent abstract from ASCO this year showing very low rejection rates using that regimen. So looking at the objective response from Murakami et al. And the cutaneous squamous cell carcinoma subgroup, we see that whether 1 agent or 2 agents were used, there was not very significant difference in objective response rate. And so I mentioned that there was an abstract published at ASCO from the Dana-Farber group by Dr. Hanna et al. Using the dynamic steroid and mTOR inhibitor maintenance immunosuppression approach. And this was for patients that were receiving cemiplimab with advanced cutaneous squamous cell carcinoma. So the patients were enrolled from November 2020 to January 2023. This is a prospective trial. It has not yet been published. At the time that the abstract was published, 10 kidney transplant recipients were enrolled. The median years from transplant were 8 with a range of 3 to 31. 6 had received prior systemic therapy. They saw no allograft rejection at a median follow-up of 6.3 months. So of the 10 patients, none have experienced rejection, and their objective response rate was 50% in the 8 evaluable patients to date, with 2 complete responses and 2 partial responses. Our local experience is similar more recently. So I'll start by presenting a single center analysis from January 2016 to September 30th, 2019, done at Mayo Clinic Rochester by Dr. Oyemi and Dr. Kukla, which involved multi-organ solid organ transplant recipients, but 7 of those were kidney transplant recipients. They noted a low rate of acute allograft rejection with only 1 patient experiencing rejection, and this patient was on prednisone monotherapy. But the objective response rate was dismal. It was 0% in the kidney transplant recipient subgroup. And the reason for this is because immune checkpoint inhibitor therapy was offered as salvage therapy. So the learning point from this trial had been, or the learning point from this retrospective analysis had been that we need to start offering immune checkpoint inhibitor therapy earlier in order to improve outcomes. So you can see here, 4 patients had disease progression and 3 patients had stable disease. And then you can see what the maintenance immunosuppression used in Mayo's patients during that timeline was. So sirolimus prednisone, TAC prednisone, TAC prednisone, sirolimus prednisone, TAC, MMF prednisone, sirolimus, and prednisone taper. And prednisone taper was the patient that experienced rejection. In the past year, I've seen 4 patients with metastatic squamous cell carcinoma. One has experienced complete remission, one has experienced partial remission, one has passed away, and one has progressive disease. I've seen 3 patients with melanoma, one who is 2 months into therapy and doing well, one who is just starting therapy, and one with progressive disease. The one patient with metastatic colorectal carcinoma with progressive disease passed away. Similarly, the one patient with metastatic hepatocellular carcinoma with progressive disease passed away. And then one patient with urothelial carcinoma that was metastatic has a partial response. And there's been no allograft rejections to date in the patients that I've been following. Our maintenance immunosuppression method differs from the Dana-Farber method in that we choose to continue patients on dual immunosuppression, and if possible, we convert to mTOR-based immunosuppression with 5 to 10 milligrams of prednisone on board concomitantly. Our mTOR inhibitor trough level targets are 7 to 10, and higher if monotherapy is chosen. So previously, 10 to 15 was used as a trough target in that prior retrospective analysis, but you can imagine this is associated with significant side effects, and so we prefer to use dual immunosuppression. If mTOR inhibitors are contraindicated or intolerable or inadequate at that time, often due to healing post-surgical procedures associated with the patient's malignancies, then we continue CNIs, and the goal trough level for tacrolimus is 6 to 8, and the goal trough level for cyclosporin is 140 to 170. We always discontinue CellCept, and these patients are typically not on azathioprine, but if they were, we would discontinue that as well. We obtain allograft biopsies if possible prior to initiating immune checkpoint inhibitor therapy to rule out subclinical rejection. But realistically, this has only happened in one of the patients so far. What we more often do is monitor cell-free DNA. So we obtain cell-free DNA at the onset of therapy, and then at 3 months into therapy, we repeat. And with no rejections so far, what we've had is a cell-free disease or donor-derived cell-free DNA results of less than 1% in these patients, but we haven't had any rejection episodes, so it's hard to say how effective a screening tool this is so far. We are not currently able to obtain PD-L1 staining, as this has not yet been clinically validated in kidney transplant tissue, but it is theorized that potentially if the kidney transplant has up-titrated PD-L1 expression, that this may be a tolerance mechanism, and this may predispose the patient to higher rejection episodes. And this has been demonstrated in preclinical cardiac transplant models as well as in liver transplants. So based on the data that we have so far, we can see that over the years, there's been a significant decrease in the rate of rejection having to do with increased maintenance immunosuppression. Specifically, the preliminary results from the Dana-Farber prospective trial are very encouraging, and our local experience since I've been here has also been very encouraging. However, we still have to be upfront with patients and tell them that all we have so far, for the most part, with the exceptions of these 2 prospective trials, are retrospective studies, and there's still, to our knowledge, a risk of rejection varying anywhere from 20% to 50%, but more likely closer to 10 to 20% with adequate maintenance immunosuppression on board. And so we have to have this conversation with patients and decide if they were to experience rejection. First of all, is that a risk worth taking for them, acknowledging that the risk of mortality is primarily related to cancer progression? And if they were to experience rejection, their risk of proceeding to allograft failure is 50%. So at that point, their options would be returning to hemodialysis or choosing a conservative management pathway. But what I found is that when we frame the conversation with regards to the risk of cancer-associated mortality and the decreased incidence of rejection that we're seeing with improved maintenance immunosuppression regimens, most patients do choose to initiate immunotherapy. Unfortunately, what we're finding is that many oncologists hesitate to have this conversation with patients because either there's not been sufficient knowledge translation of these more recent prospective trials, or because the teaching that they have had to date is to defer immunotherapy until they have failed other lines of therapy. And what we've seen historically at Mayo Clinic and also in these retrospective studies is that the longer you wait before offering immunotherapy, the less likely that these patients are to respond. And so ideally, we would have a team-based approach where when these patients present with advanced cancers or metastatic cancers, where immunotherapy would be the first line option if they were part of the general population, then a conversation should be initiated with those patients' kidney transplant team about potentially offering immunotherapy as first line, and what can be done to optimize the maintenance immunosuppression prior to starting immune checkpoint inhibitor therapy if the risks are acceptable to the patient. So to conclude, cancer is a leading risk of premature death post-kidney transplant. There's been multiple studies in transplant recipients undergoing immune checkpoint inhibitor therapy that have demonstrated that cancer progression is the most frequent cause of premature death rather than allograft failure post-rejection. We're seeing decreased rejection risk with improved maintenance immunosuppression strategies. And there are likely multiple effective methods to adjust immunosuppression. So there's not a one-size-fits-all approach, but these methods remain to be determined. Other questions that we still need to answer are there effective non-invasive biomarkers? So I mentioned using urinary CXCL10 as a potential biomarker, as Dr. Carroll et al. Did. We're using cell-free DNA assays. We also need to better understand how to risk stratify patients with regard to their rejection risk and the optimal timing of immune checkpoint inhibitor initiation, as well as what is the likelihood that these patients would have a poor response to immune checkpoint inhibitor initiation? Because if that's the case, then potentially for those patients, the risk of allograft rejection and failure is not worth it. So further studies are needed. I would just like to acknowledge Dr. Kukla and Dr. Oyemi for their mentorship and for allowing me to follow these patients longitudinally, and Dr. Isa, my program director, for giving me the time to do so.
Thank you. Great. Well, thank you for that phenomenal update on where we are in the context of these quote unquote new-ish agents, as you pointed out. Dr. Neufeld has a question about, can you speculate on why there was no association seen between AIN-associated drugs and IAEs in transplant patients in the one study?
So it's really unclear. I mean, maybe the maintenance immunosuppression decreases the risk of reaction to self-antigens, because the idea with the AIN-associated drugs is that you have haptens within the renal parenchyma expressed on tubular epithelial cells that then act as triggers for self-reactions, but potentially with the maintenance immunosuppression, we're seeing less of that. The other thing too is looking at that study done in Tel Aviv at the Sourasky Medical Center, there were fewer naive T cells and more memory T cells. And so potentially when we amplify the immune response, the amplification we're getting is more of a memory T cell response, less of a naive T cell response, and this may be decreasing the likelihood of AIN-associated drug response.
Great, thank you. Another question. In your experience and review of the literature from Dr. Justin Gill, what are the thoughts on the risk of the recurrent or de novo glomerular disease post-transplant with immune checkpoint inhibitor therapy?
That's a great question, and that's not really one that I have seen answered in these retrospective studies. But I definitely think it's worth looking into, because that's something that we look out for patients receiving immune checkpoint inhibitors who have a history of GNs and native kidneys. So that requires more investigation.
Yeah, I guess the people with GN as their native disease who get a transplant I don't know if there are any data. Are they more or less likely to develop cancer because they would have had double exposure, right, to immunosuppression, and younger,
Yeah.
therefore more time. But I don't know if you've seen that.
And
Look,
anecdotally, I've seen that patients with a history of GN who go on to kidney transplant develop more cancers. But this is just anecdotal
yeah,
experience.
great. Oh, more questions coming in. It's not part of your presentation, but how can we improve on cancer screening in general in our transplant patients? We found the screening practice, I think this is a really important thing. The screening practice is not consistent among transplant centers.
That's also a very good question. I think the highest yield areas that we can look at are screening for cutaneous squamous cell carcinoma. And unfortunately, there's conflicting literature as to when the risk of metastatic cutaneous squamous cell carcinoma occurs. Is it after a first lesion that you need to worry? Is it after 4 lesions that you need to worry? Retrospective studies have suggested different things, but working with some of the dermatologists here, they've noted that these patients will present for their yearly screening dermatology exams, which are increased to every 6 months once they have had a diagnosis of either SCC or melanoma. And within that time span, even within the 6-month time span, a patient can go from having an in situ carcinoma to having locally advanced or metastatic carcinoma, even though they had that initial lesion treated. And so we know that there's a subset of patients who have these very aggressive phenotypes, but we're not really sure yet how to risk stratify these patients, because it is asking a lot for a patient to return. The Mayo model is kind of strange, where they're a destination medical center with patients flying in for their appointments. There's very few patients from the area that come. And so if we're already asking them to come every 6 months, that's high burden. To ask them to come even more frequently would be challenging, but then we have to sort of coordinate with local dermatology providers to do more frequent checks. And we don't have data to say this is the timeline at which the check should occur to make sure that we're catching these metastatic or these locally advanced instances early. What we're looking at right now is whether we can look at molecular diagnostics to risk stratify these patients, but there's nothing really definitive yet. And then the other big thing is HPV screening, and then whether or not we ensure that patients have been vaccinated for HPV prior to receiving transplants. And then for women, the frequency of pap smears. There's not been agreement on the frequency yet, to my knowledge, but we definitely as a transplant community, I think, need to come up with better screening guidelines.
Great. So 2 more questions. Can you re-challenge ICI following AIN in native and transplant kidneys?
So definitely for native kidneys, you can re-challenge, and there's a 20% risk of recurrence of an AIN. But often the recurrent AIN will still be responsive to steroid therapy. And then in terms of re-challenge in transplant patients, our local protocol is to re-challenge if the patient is willing to accept the risks. Of course, this is if they've had an episode of rejection and they've responded to therapy. If they're on dialysis and they've been on dialysis, it's a different story, because at that point, the main focus becomes treating their malignancy. But if they've responded, then our protocol is to re-challenge. But we don't really have any data guiding that decision.
Right.
So
a related question would from Dr. Horgan is whether you should we institute a dynamic steroid protocol? Should that be used routinely in all patients at the start of checkpoint inhibitor therapy, or only in selected patients? I suppose it's.
I think it's important to set a protocol, because if you set a protocol, then you can sort of monitor the response to that protocol and adjust it as needed over time. And so my bias is dual immunosuppression because of my experience at Mayo so far, but the Dana-Farber bias is dynamic steroids plus mTOR inhibitors based on their experience. both of us have had good results so far, although their objective response rate was better in that abstract that was published, but it was specifically looking at cutaneous squamous cell carcinoma patients who were on cemiplimab, whereas we have had a variety of malignant lesions, so it's hard to compare. And ours is just retrospective, it's not a prospective analysis. But choosing either or, I think, is the way to go, and then monitoring the response. And of course, you also have to decide what you want to do for patients who are high risk for rejection. So the Dana-Farber abstract didn't include whether or not those patients had pre-existing DSAs or what their HLA mismatch was. So it's hard to say what their risk for rejection was at the outset. If you have a patient that you're very concerned, then you might want to maintain triple immunosuppression. Or, for example, pancreas transplants. We don't have a lot of data for pancreas transplants, but the little data that we do have shows that they are at very high risk for rejection. And so in those situations, continuing triple immune suppression as maintenance would make sense.
Great. No, thank you for those answers. I know we have a lot of colleagues from the BC Cancer Agency on the line, because at least I think we do, because of the names that I have no recollection of. So if anyone has any specific other questions, happy for people to ask them. Yeah, I think just while we're waiting for one, I think one of the things that's important is that whatever protocol one decides on, to use it, assess it, and then decide whether it needs to be changed or not. And I think that approach is important. And I think it was Dr. Burks that asked the question with respect to, or somebody, about the non-standardization of screening for transplant. I think that is something that is, from what you and others have said, it seems to me low-hanging fruit. Like, just pick something and then implement it and see if that improves. There are two more little questions. If a patient has a known baseline DSA prior to initiation of immune checkpoint, is your local practice to switch to sirolimus or just keep the person on TAC?
It depends on the MFI. And so I think for us, the MFI cutoff is 2000. And so if it's greater than 2000, then we would continue triple immune suppression or their maintenance immunosuppression at that point. But if lower than 2000, then we would switch to mTOR inhibitor.
Great. And the related question is curiosity as to why the discontinuation of MMF is part of some of the protocols, given that it reduces rejection risk and is also a potential treatment for AIN associated with ICI. So would you consider a reduction of MMF versus a complete cessation?
I think it's just because there's a preference for mTOR inhibitor use due to, first of all, its utility as secondary prophylaxis in patients with cutaneous squamous cell carcinoma, as well as there's been one case report that looked at the mechanism by which mTOR inhibitors may reduce the likelihood of rejection in conjunction with ICI therapy use, and may also increase tumor response to ICI use. So for that reason, we prefer mTOR inhibitors over MMF. And then, if we're going to continue somebody on triple immunosuppression because we think that they're high risk, then at that point we would maintain CellCept on board. There's also a practice at Mayo Clinic to discontinue CellCept whenever patients have new malignant diagnoses. And I think just due to the concern regarding the antiproliferative effect on cancer progression. Now, whether or not that's justified, I think is a different question, but that was the protocol previously as well.
Right. I think, yeah, things creep into practice based on theory of the day, and then possibly aren't rethought about or rechallenged. So these are all excellent questions. So we're coming to the end of the hour. I want to thank you for making the time so close to the holiday season, Dr. Babir, for an excellent and thorough presentation, and for all of the colleagues who joined. Thank you for your questions and your interest, and very much appreciate the transfer of new knowledge for so many of us. Thank you.
Thank you, Dr. Levin.